Good afternoon, everyone. My name is Marissa Weiss, and I am from the Lymphology Marketing team here at JOPES. Thank you for joining us today for our webinar series. Our topic is breast cancer and lymphedema. We hope you find it interesting and informative. As this is a recorded session, we will not be taking questions at the end. However, you can direct any questions to me, and I will help get them answered. I'm now going to pass over to our host and very excited to announce her, Dr. Nicole Stout.
Thanks, Marissa, and thanks to JOPES for setting up this webinar series. What I want to talk with you today about is the idea of prospective monitoring and early intervention for lymphedema. We spend a lot of time talking about how to treat lymphedema and manage it with interventions once it occurs. But what I want to do is encourage you to think a little bit differently. We know there are a cluster of events that occur with breast cancer treatment, and we know that there are risk factors, each of which contribute to the development of lymphedema. We have an opportunity with cancer treatments to use a prospective approach to monitoring so that we can identify clinical changes early that are consistent with the development of lymphedema. So we'll talk through that model and some of the evidence that supports it today. So our objectives, I want to talk with you about some of the clinical diagnostic thresholds. At what point does someone eclipse a threshold that is meaningful for the diagnosis of lymphedema? And some of those are different based on the different tools that you would choose to use. We'll also talk about optimal screening and assessment pathways so that you can assess proactively limb changes that are consistent with the development of lymphedema. We'll talk a bit, too, about risk stratification strategies because we know there are a number of factors that we can identify at the point of diagnosis or early on in the cancer care plan that tell us a story about that individual's level of risk, help us to stratify, and then to appropriately manage them prospectively. And then we'll also talk about some of the evidence-based conservative interventions for early lymphedema management. It's important to recognize that early identification means conservative intervention. That doesn't mean that we negate complete decongestive therapy, but in an early stage, our individual patients may not need comprehensive and intensive decongestive therapy. So by identifying lymphedema early, we may be able to offer them a more conservative approach to adequately managing their condition. One of the things that I think is very important for us to reflect on are the incidence rates of lymphedema now that we live in the sentinel lymph node era. In 2003, sentinel lymph node biopsy became the standard of care in managing breast cancer. And what we've identified since that time is, although the sentinel node biopsy reduces the number of lymph nodes removed from the surgical procedure in the axillary region, it also contributes to reduced size of the surgical healing site and improves postoperative function. What we know, though, from sentinel lymph node research is that even though the number of nodes reduced is less, we still do damage to the lymphatic system on several levels, and therefore we still see an incidence rate of sentinel lymph node biopsy. Of lymphedema with sentinel lymph node biopsy. What you see here in this slide is pooled incidence rate looking across a number of different studies. This was data that was aggregated by Dr. Simone Schadelman and a research group that published an update on the evidence in lymphedema management in CA, the Journal for Clinicians. So you'll see the sentinel node rate of lymphedema measured at about 6.3%, still significantly less than what we see in axillary lymph node dissection at about 22%. But what's important to note here is that the sentinel lymph node biopsy does not eliminate the potential for developing lymphedema. So there's no 0% risk here. So even with a less intensive surgical procedure, there is still risk that we have to consider for the development of lymphedema. And this also tells us that the number of lymph nodes removed matters. Lower number of nodes, smaller surgical incision, and the risk is significantly less. The other thing that was identified in this report was that the extent of radiation matters. We've been capturing in research the degree to which we radiate the chest wall, whether it's the breast, whole breast irradiation or the breast and the regional nodal irradiation into the lymph node bed. And again, what you can see here is the differentiation between risk among those who have had axillary node dissection and sentinel node biopsy. So yes, with sentinel node biopsy and with less radiation, there is lower risk. These metrics help us to begin to stratify what we know to be true about our patient's risk for developing lymphedema. And we're going to come back to that idea of risk stratification, as it will help us to enable a more precise and more tailored intervention pathway for early identification of lymphedema. So when we talk about early identification, the model that comes to mind is the prospective surveillance model. This was initially published in 2009 as a pathway for early identification of lymphedema in a research study in a cohort of breast cancer patients. This model has since evolved significantly, and in 2012, the American Cancer Society published a supplement issue to the journal Cancer that articulated and expanded on the prospective surveillance model. The premise of the model is this: if we can identify at the very point when an individual is diagnosed with cancer, we can identify their relatively normal state of function, their limb volume, their strength, their range of motion. In other words, we take those baseline metrics. That helps us to understand their preoperative body habitus and function. We consider that their normal baseline. We then begin to follow them at prescribed intervals throughout the course of their cancer treatment, knowing that those punctuated interval changes that will occur throughout cancer treatment, like surgery and chemo and radiation, will all bring with them a slightly elevated risk for functional decline, including the onset of lymphedema. So the idea behind prospective surveillance is identify the normal baseline for an individual, follow them throughout the trajectory of cancer treatment at intervals, and repeat those baseline measures to identify if there have been meaningful changes that have occurred. If meaningful changes occur, i.e. they begin to develop clinically meaningful swelling, we initiate a more intensive rehabilitation intervention. So the idea of prospective surveillance is not to wait until we see swollen arms or swollen fingers, but to prospectively measure repeatedly so that we can identify the early emergence of those symptoms. So the surveillance model enables early detection of and intervention for treatment-related impairments. Today we're talking specifically about lymphedema, but we want to keep in mind that these individuals often experience an aggregate burden of impairment that goes along with cancer treatments. So other things like fatigue and neuropathies can also be identified early if we use this model of a population-based approach with consistent methodology for ongoing functional assessment. So the key with the prospective surveillance model is at baseline, we identify a battery of tests and measures, and we simply over time repeat those tests and measures, and we look for meaningful change to then intervene. What's important and critical is that we use a consistent methodology for that ongoing repeat assessment. So we want to choose our clinical assessment tools. We want to repeat the use of those tools and do so in a standardized way so that we're comparing apples to apples over the course of time. The premise here is that surveillance will help us to identify an impairment in an early stage when it is less severe, and that diminished severity at the onset will help to perhaps prevent impairment and functional loss in these individuals over time. Overall, our goal is to try to optimize our patients' functioning. We want to try to get them back to their pre-morbid level of function. This should be a standard of care for every individual and a standard goal for every individual going through cancer treatment. The prospective surveillance model also allows us to proactively engage in educating our patients about activity and exercise prescription. So we start at baseline at the point of diagnosis of cancer prior to the onset of any interventions. Why does it matter that we see them before intervention? Well, if you think about someone who's been diagnosed with breast cancer yesterday, She probably took her kids to school. Maybe she went to the gym, did all of her household chores, and was existing in her normal life. And today she's been diagnosed with cancer. And tomorrow, or in several weeks, she will begin these treatments that will deplete her function. So if we can take the time at that point of diagnosis to identify what is the baseline normal for this individual, we can capture that and we can track change over time. Eventually, we will continue that interval surveillance, approximately 1 to 2 weeks, or sometime within that first month post-surgically. And the initial prospective surveillance model is based on a 3-month interval follow-up over 1 year, and then 6-month intervals out to 5 years. Intervention comes about, and we triage individuals to more intensive intervention if and when impairments are detected. We have to think about the span of treatment for cancer, breast cancer specifically. Typically, this occurs over the course of anywhere from 9 months to 1 year. And then beyond that, usually hormonal therapies for individuals in whom they're indicated will continue even up to 5 years. Not only that, we know that many cancer treatments have late impact or cause late effects on the body. And so sometimes the side effects don't appear until several years after the completion of treatment. So if we think of cancer as a chronic disease, which is what we've become to recognize it as, really this interval surveillance and focus on function becomes a lifetime endeavor. So this is a depiction of the prospective surveillance model for physical rehabilitation for women with breast cancer as it was published in the supplemental issue for the journal Cancer in 2012 from the American Cancer Society. And you can see here again that trajectory of medical management along with the preoperative, early postoperative, and then ongoing surveillance interventions that are requisite of the model. You'll see the impairment detection and identification management clinical measures, as well as the health promoting skills and behaviors. Because as we said, this isn't just a time to clinically assess, it's also a time to educate and engage and begin to develop relationships with our patients that will help us proactively, optimally assess and manage their condition. Interestingly, in 2013, the Institute of Medicine identified that the cancer care continuum, typically in the past, we've thought of the cancer care continuum really as beginning at diagnosis and proceeding through medical treatment. And the IOM basically created this schematic that you see and said, yes, it's important that we identify from diagnosis through treatment, survivorship, the medical basis for intervention that you see here. But in the blue arrow that you see along this continuum, they identified that what we're not doing very well is proactively assessing for and managing care planning or psychosocial needs of patients, as well as long-term and late effects that impact function and functional morbidity. So in essence, what the Institute of Medicine said is we need to do a better job of starting at the point of diagnosis with the identification and management of many of these long-term and late effects, lymphedema included. So really what you see here in the blue box, this is a call to rehabilitation. We really need those rehab providers at the point of diagnosis to help with comprehensive care planning and prospectively monitoring for early identification and management of these late effects of disease. So let's put this into the breast cancer context. If we begin at the point of diagnosis, we fully anticipate that in that early postoperative phase, there will be some limitations, probably in range of motion, in mobility, some scar tissue issues that we may have to deal with. We also fully anticipate that as an individual moves through cancer treatments, chemo and radiation therapy, there will be sequelae to those interventions that can cause additional treatment-related morbidity that contributes to a decline in function. Overall, our optimal goal should always be returning these folks to the highest level of activity that they choose to be engaged with. So it makes the most sense for us to think about following proactively along this trajectory so that we can optimize at every one of these points rehabilitation, early postoperative rehabilitation, inter-treatment rehabilitation interventions. Each of those time points help us to optimize their level of function. So the point of the preoperative visit, as we said, obtain those baseline measures, but also recognize at the point of a cancer diagnosis, an individual may have pre-existing conditions that can contribute to functional compromise. So if an individual comes into cancer treatment with a history of frozen shoulder or a history of lymphedema, we need to be aware of that. So the baseline assessment helps us identify perhaps there's a time point here before they begin treatment where we need to intervene with therapeutic interventions that can help to minimize that impairment and really get them ready to go into cancer treatment in a better functional status. This is also an excellent opportunity for us to begin to prescribe exercise, talk with them about the anticipated postoperative course of care, what types of signs and symptoms they should be looking for that are of concern, and what types of exercise and activity they can begin to re-engage with in that immediate postoperative time period. Subjectively here, I want to ascertain from my patient what their understanding of the disease process is. This is a great opportunity for me to begin a dialogue with my patient so that they have an understanding of why these lymph nodes are being removed and how it can potentially impact their function. What are the reasons that the nodes are coming out, and why are we talking about lymphedema today when I don't have any problems? So we want to begin that understanding of their knowledge and start to build their knowledge base. We can also take a number of baseline measures. Objectively, we certainly want to assess their movement, their range of motion, their strength, muscular endurance, as well as their limb volume. At this point, again, in a relatively normal state, we want to make sure that we assess limb size on both the involved and uninvolved limb. I'll tell you a story about a patient that I saw. She was a horseback rider, and she would tether with her right upper extremity. And her diagnosis of breast cancer was in the left breast, and so her left upper extremity would be compromised. Her right arm was 14% larger than her left arm at baseline, and that was because of her natural activities of daily living. It was very important for us to quantify this difference at baseline to know that interlimb volume disparity existed. If we would have never seen her at baseline and maybe saw her 3 or 6 months down the line, if she became symptomatic and her left arm even had a slight bit of swelling, we may have missed the earliest onset because we would measure her limbs and say, well, the right side's 14% larger, the left side's significantly smaller. So in the absence of having those baseline measures, we don't have a comparison, a normal comparison. So it's important to have those baseline measures because under normal circumstances, we have about a 3 to 5% interlimb volume variance. So we want to be able to quantify that at baseline and know what's normal for each individual so that as we follow them prospectively, we can identify the earliest clinically important change. This is also a time for me to begin to educate my patient about lymphedema risk. What is lymphedema? How does it feel if your arm starts to change? What's clinically meaningful? What should you expect following surgical treatment? Swelling or no swelling? Puffiness? Different sensations in the upper extremity? When will I see you back in the postoperative time period? So at this preoperative visit, it really allows me to set the stage and begin the education that these individuals need to have. Again, as I said, we can also introduce exercises here through a tailored program to the individual if they have impairments at baseline or if we know that they're going to need specific exercises postoperatively. In that early postoperative time period, usually we recommend that first follow-up visits somewhere between 1 to 2 weeks postoperatively. Ideally, it occurs within 1 month of the surgical procedure. This is generally in an outpatient ambulatory clinic, and the purpose here is to identify how they have changed since the surgical procedure. So we fully expect to see some limitations at this point. Subjectively here, I'm able to gather more information about the patient's disease process and the anticipated plan of care, because now I'm going to have a more concise pathological report after the surgery. I will know how many lymph nodes were taken. I will have a more definitive stage of the disease, and I will know what treatments are now anticipated. This is really important if we go back to the idea of risk stratification. I can begin to build a risk strategy in my mind if I understand if my patient has had 3 lymph nodes taken versus 20. If I know that my patient has a stage 3 breast cancer versus a stage 1. So each of those bits of information are factors that help to contribute to the risk stratification. At this point, as I said, I anticipate seeing some level of decline in function. Most of these individuals will have had limited range of motion restrictions post-surgically, especially if they had a drain in place. But I still want to repeat my objective measures of strength, range of motion, muscular endurance, and limb volume on both extremities. At this point, as far as my assessment and plan, I can continue with my education role. And here again, I'm simply, in most cases, repeating to the individual advice and recommendations for exercise, perhaps a tailored impairment-based program for restoration of range of motion, flexibility exercises, indications for lifting and carrying and returning to activities, and especially the idea and concept of lymphedema monitoring and risk reduction. So talking about the symptoms associated with the onset of lymphedema. Now, at this point also, there is a potential need for us to introduce self-manual lymphatic drainage in most individuals. We should be prescribing this proactively. There's a good evidence base that suggests that incorporating self-MLD techniques, simple techniques that address deep breathing in some of the proximal central regions of the lymphatic system, like the cervical nodes, and the contralateral healthy lymph node beds, at this point can help those lymphatic drainage channels to open and begin to move fluid so that it does not begin to congest in the upper extremity. So I continue my interval surveillance every 3 months for the duration of the first postoperative year. I anticipate subsequent visits at 3, 6, 9, and 12 months. Now, it may be a challenge for you as a therapist to be in the clinic to see these individual patients when they come in for their physician visits. But it is important if we can be proactive and have these folks engage with proactively setting up their appointments and being at an interface with the patient is the most important. We also want to remember here that along the course of the trajectory, again, we're identifying changes significant for the development of lymphedema. But we also want to remember that there are a number of other impairments that can present during this time, which, if we're continuing to repeat our baseline measures, we may be able to identify early and help to prevent functional decline. Things such as fatigue, reduced levels of mobility, chemotherapy-induced peripheral neuropathies. We anticipate this aggregate burden of impairment, and we recognize that by using the prospective surveillance model, we may be able to identify the onset of these conditions early and then triage for more conservative rehabilitation interventions. So throughout each of these visits, I'm just continuing to reassess subjectively how is the patient's quality of life, their arm function, any new or emerging problems that they have identified. I also want to understand the changes in those objective measures. So I'm simply repeating each of those measures that we talked about, range of motion, strength, etc. If I identify a clinically significant change in their limb volume, we've identified the diagnostic threshold for lymphedema at greater than 5% increase in limb volume based on that baseline measurement and with consideration for the contralateral limb. If I identify that 5% change, I want to triage my patient for a conservative intervention to begin to manage their lymphedema. The subjective symptoms around arm function and sensory change are also important here throughout this time period. Most of the time, if individuals develop the onset of lymphedema, there are symptoms that occur as precursors to the onset of swelling. Those are manifest as sensory symptoms in the affected upper extremity. Things like heaviness, aching, diffuse tingling in that affected extremity. Based on Dr. Jane Armour's work, we know that those symptoms can be predictive of the onset of lymphedema. So by combining my subjective report from the patient and understanding any sensory changes that they might tell me about, or if they have seen swelling, even if it has dissipated completely, along with my objective measures, can give me a very clear picture of an emerging presentation of lymphedema. So at this point, as I'm moving through my interval surveillance, if I do identify impairments, I triage the individual for an appropriate frequency and dosing of an intervention. And there may be, most of the time when I see an individual, I may just say, everything looks great, your measurements are good, your mobility is good, keep doing activity, and I'll see you back in 3 months or in 6 months. However, if I do identify that there are changes consistent with swelling, I will intervene with a more conservative intervention. So what does that look like? Well, as we described in our 2009 article, and this was based on the research studies that we conducted at the National Naval Medical Center in Bethesda, our cohort of patients were all seen preoperatively, and we set our diagnostic criteria at 3%, a lower threshold, a subclinical threshold that we were able to identify using optoelectronic pyrometry. We followed these patients using the prospective surveillance model on a 3-month interval. If individuals developed more than a 3% volume change based on their preoperative measure and with consideration for their other limb, we put them into a Class 1 compression sleeve off the shelf and Class 1 gauntlet off the shelf. We advise them to wear that compression sleeve and gauntlet daily over the course of 4 weeks. So no nighttime wear and no restrictions in activities. We encourage them to keep going with all of their regular activities of daily living, even if that included exercise or heavy lifting or strenuous activities. And after a 4-week time period, we reassessed their limb. If at that time period individuals experienced an exacerbation or if their volume had not responded, we would initiate an intensive decongestive therapy program. 100% of the patients in this trial demonstrated volume decrease that was significant, almost to normal. And so therefore, we put them back on their 3-month follow-up regimen along the prospective surveillance model. At this point, we took them out of the daily sleeve wear and we told them to only wear the compression sleeve if they became symptomatic and had sensory changes in the limb. They visually saw that they had swelling. They would then use the compression sleeve. Or if they knew they were going to do an activity or an exercise that was above and beyond their normal tolerance or would cause them strain. So we gave them those indications. We followed this cohort out over 1 year and found that none of them progressed to a more advanced stage of lymphedema. The other thing that we were able to do using the data from this study was to identify that when we're talking about an early presentation of lymphedema, the subclinical changes that occur can be sensory, can be indicated by sensory changes, as we said, based on Dr. Armour's work. The feeling of congestion is telling your body a story. It says it's heavy, it's achy, it's tingly in this limb. So those sensations will occur many times before we can visibly see swelling changes. The other thing we know about the onset of lymphedema is that it is typically slow and gradually progresses over time. It is the rare circumstance when someone wakes up one day with their entire arm, hand, etc., being big and puffy swollen. Typically what happens is a very slow progression over time. So what we were able to identify was that there are in fact areas of the limb that are precursors to the development of lymphedema, subclinical lymphedema. We identified if we take the limb from the wrist up to the axilla at 10 centimeter intervals, the intervals right around the elbow, just below and just above the elbow, those two intervals would show significant changes in limb volume prior to the onset of lymphedema in our patient population who went on to develop lymphedema. So those two segments, just below and just above the elbow, were in fact highly predictive of the onset of lymphedema. So let's step back and think about that clinically for a moment. If I don't have a fancy, sophisticated, very expensive tool like a pyrometer, which is what you see here, the output, and you just have a tape measure, fantastic. Tape measures have very good concurrent validity with the pyrometer and with water displacement, which is, as we know, the gold standard. So if I'm doing my tape measure, circumferential measures from baseline, and I'm monitoring in a prospective fashion, and I identify a 4 or 5% volume change, maybe I don't see anything visually on the limb, but my patient is telling me they have sensory changes. And when I look more closely at those areas around the pericubital region, just below, just above the elbow, and I see that those are, in fact, much larger measures than they were in my previous session, I have just identified the earliest onset of lymphedema, and I want to manage it conservatively with that compression intervention that we just talked about. So putting this into context clinically, we know there are some symptoms that we can identify that tell us a story that lymphedema is starting to occur in the interstitial tissue. And there are some markers on the limb, some specific areas on the limb that we can look at that tell us there is an emerging condition here that's congesting in the interstitial spaces. Now, quite a bit of evidence, and I'm just going to touch on these briefly. I've given you a reference list here at the end of the slide deck presentation, so you'll have the full references for these. But I think it's important to recognize that since we published these initial articles in 2008 and 2010 and 12, we have seen an emergence of evidence supporting the prospective surveillance model for early detection and management of lymphedema. And much of this has been accelerated because we have very sensitive tools like bioimpedance spectroscopy, and that has really started to drive some of the guidelines and some of the proactive measurement strategies in early identification of lymphedema. So what we see here is that prospective surveillance programs can help us to identify lymphedema early using bioimpedance spectroscopy and the prospective surveillance model, so getting that baseline pre-treatment measurement, following higher risk individuals in a prospective manner helps with the earliest identification and early management and may prevent the progression to a more severe condition of lymphedema. This group from South Korea, Yang et al., also identified that over the course of a 5-year follow-up period, their patients who underwent the surveillance program had a significantly lower incidence rate of more advanced stage 2 lymphedema at 5 years than the usual care group. So that's good news. I think it's very important to recognize that using prospective surveillance as a methodology doesn't mean that we're going to prevent lymphedema from occurring, right? You hear the subjective reports of heaviness, aching. We're still doing damage to the lymphatic system. We still see these early onset of swelling and congestion occur. But what prospective surveillance does is it gives us an opportunity to identify those changes at their earliest point and manage them proactively and perhaps prevent the progression of the condition to a more advanced stage. Now, as I said, we're talking here about lymphedema, which is of critical importance because we know it's a lifelong condition. And boy, if we can prevent it from progressing to a more advanced stage, what a great opportunity for us to improve function and quality of life for our patients. But I think it's also worth mentioning here that there's strong evidence about using the prospective surveillance model to help to optimize and restore shoulder mobility after surgical intervention. So alleviating conditions like axillary cording, helping to promote improved scapular stability and strength, and improving range of motion proactively. All of these can also help to impact long-term outcomes, not just functional outcomes of the upper quadrant, but also think about the lymphatics in the axilla. If we have tight adherent scars in the axillary region, If our patient does not have full upper extremity range of motion and tissue excursion in the axilla, there's a risk that the lymphatics there are not able to adequately move fluid, and the congestion can be furthered by tight adherent scars and by tissue that is contracted. So mobility of the upper quadrant and the shoulder matters to the development of lymphedema and matters to fluid evacuation and movement into and out of that upper extremity. Again, just further research here from Dr. Lai and her colleagues at Emory University that looked at implementing this prospective surveillance model over the course of 1 year and found higher level improvements in overall function. The upper extremity function index and the disability of arm, shoulder, and hand scores were much better in the intervention group, which was the prospective surveillance group. This model is feasible. The visits that are required throughout the intervals of care are relatively inexpensive. They can be conducted by a physical or occupational therapist, and those visits are covered as reimbursable visits under most health insurance plans, as well as by Medicare and Medicaid. So not only were the costs relatively low and typically covered by health insurance, but there's also clinical uptake that occurs. The education and awareness of our patients is better, but the education and awareness of our healthcare providers along the oncology continuum is also better, making this model even more requisite. One of the other studies that I'll share with you is going to bring us back to this point of risk stratification. If you've never read any of Dr. Shamley's work, I would encourage you to look her up and identify some of her studies. She does a really nice job of talking about proactively managing these upper quadrant issues to prevent functional decline and early identification of lymphedema. So she has developed a risk stratification process whereby at the point of diagnosis and shortly after surgery, when we understand the patient's physical and functional habitus, their body habitus, their physical and functional status, we can begin to stratify who is at high risk for compromise and who is at low risk. Once we do that, we then apply interventions to the high-risk group, probably more intensively. Perhaps we provide them with more extensive education. We give them more modes of educational tools. We can also see them at more frequent intervals during the course of their treatment because we know they are a higher risk group. So risk stratification helps us to tailor our intervention in a more specific way, either by more or less screening, more detailed or less detailed assessment, and then understanding the pathway by which those individuals and where along the pathway those individuals may encounter clinically meaningful changes that will warrant intervention. So let's take a breath and let's think about how do we put this all into practice. This is a lot of information that I've shared from the prospective surveillance model, the various clinical tools and measures that can be taken at baseline and at those interval follow-up visits, where and how we do this with the patient, and what factors do we need to consider. So how do we bring this all together and put these pieces together? So let's start with that risk discussion. What do we know about risk and what do we do about it? Well, as we said, from baseline, we can have an understanding of the individual's level of function. We can take baseline measures of their limb volume. We can also understand if they have any pre-existing conditions that may contribute to increasing their risk of developing lymphedema. What do we know about risk factors? We know that the number of lymph nodes removed matters. More nodes equates to a higher level of risk for developing lymphedema. We know that a BMI over 25 at baseline or an individual who gains weight and her BMI exceeds 25 during cancer treatment is a risk factor for the development of lymphedema. We know that radiation therapy, especially regional nodal irradiation, increases risk. We also know that if an individual has a sentinel node biopsy and the nodes are positive, depending on the treatment intervention, they may have a re-excision, meaning that they'll go back in surgically and take out more lymph nodes. That also contributes to an elevated risk. If the individual has a postoperative seroma, seroma is one of those unfortunate circumstances that occur when the tissue in the axilla or on the chest wall doesn't adhere nicely after the surgery, and a little pouch of fluid can occur. Those factors we know contribute to the highest risk of developing lymphedema over the course of time during and after breast cancer treatment. So what do we do? How do we manage those? Well, we establish our baseline and we follow that individual proactively to monitor for ongoing changes. We provide them with extensive education around early symptoms of swelling, the heaviness, the numbness, the aching, the tingling, exclusive to the involved extremity. It's also important for us to impart upon our patients the knowledge that symptoms that occur are occurring for a reason. There's no such thing as, well, maybe I'll just wait and see if it goes away. Or maybe it's just a little bit of swelling and it's not that important. I impress upon my patients, there is no such thing as a little bit of swelling. The littlest bit of swelling is telling us a story that your lymphatic system is teetering on the edge. And the earlier that we can intervene to help to support it, the better off they will be in the long term. And perhaps we can prevent that congestion and tipping into a more advanced stage of lymphedema. So the extensive education that they need repeatedly over time is something that we can do not only to talk to them about risk, but to perhaps minimize the risk of them developing early symptom changes that go unmanaged. We also want to prescribe exercise. There is some evidence that resistive exercise training helps to build lean mass, which may be preventive in the onset of early lymphedema. And teaching self-manual lymphatic drainage should certainly be a part of our plan of care for every individual, as it may help to reduce the risk of congestion of lymphatic fluid in an involved upper extremity. So as we move through our trajectory of the prospective surveillance model, we've talked about screening. How do we screen and how do we assess? These are two different things. Screening should be simple and easy. One question, two questions. Have you had symptoms? Have you had swelling? If the patient answers yes to that, that should be an immediate trigger for a more detailed assessment for us to move into identifying if there are clinically meaningful circumferential changes, clinically meaningful changes on bioimpedance analysis. But that simple screening tool, yes, no, can be done by anyone. That can be the physician, the medical oncologist, it can be the nurse. If you're working in a system where you have one of those fancy electronic medical records that enable alerts, you can embed into your electronic medical record program. The decision support tool can embed a question that triggers for every breast cancer patient at every visit with their oncologist. Since the diagnosis of breast cancer, have they experienced arm swelling, yes or no? And if they tick the box yes, it should populate an automatic referral for rehabilitation assessment. So we talked about assessment. What are the tools that are most valid and most acceptable clinically for assessment? We have a lot of different tools that we can measure the limb volume and limb changes over time. Recently, the American Physical Therapy Association published a clinical practice guideline, and they highlighted these three clinical assessment tools. Now, let's not forget about water displacement. We know how exceptionally sensitive and specific water displacement is, but we also know that we have challenges with the clinical feasibility of utilizing water displacement. So circumferential measures, highly sensitive and specific to the early onset of lymphedema, using a 5% volume change if we assess preoperatively, following prospectively, and with consideration for the contralateral limb. Using our bioimpedance analysis, the LDEX unit was found to have very high sensitivity and specificity at identifying early limb volume changes. Again, if we look at the guidelines that have been published around the use of bioimpedance analysis, they suggest preoperative assessment and ongoing interval surveillance for the earliest identification of lymphedema. The moisture meter D was identified as a potential, this is a tissue dielectric constant, And it is a potential and emerging technology that has fairly good feasibility and clinical acceptability, but we just don't seem to have the bulk of research yet in identifying whether this is a clinically valid tool to the same level that bioimpedance and circumferential measures are, but certainly emerging in the literature. So these tools, repeated over time at appropriate intervals, can help you to optimally enhance early identification and promote early management of lymphedema. Now, you may or may not have seen this tool. This is just one example of a screening tool that's typically given to individuals going through cancer treatment. In 2012, the Commission on Cancer, which accredits the majority of the cancer centers in the United States, issued a standard for accreditation and said, we need to assess distress in individuals as they are going through cancer treatment. So we've created a number of assessment screening tools, the stress screening tools, if you will. The distress thermometer that you see here is just one that was developed by the National Comprehensive Cancer Network. So at each visit, at each medically important visit, intervals of care, as identified by the Commission on Cancer Standards, the patient is supposed to receive a distress screening, and the patient can tell you the level of distress that they are experiencing using a visual analog scale here from 0 to 10, for example. And to the right side here, you see the problem list articulated, and you do see the physical problem feeling swollen as a part of the distress thermometer problem list. So if an individual were to identify that they're having distress and that distress is because they have swelling symptoms, this is an excellent screening mechanism to trigger a triage pathway for a referral to rehabilitation so that we can do that more detailed assessment. Ultimately, the goal is for us to get the right intervention at the right time applied to these individuals so that we can either reduce risk, help to mitigate the risk of developing the onset of lymphedema, or if they do show the earliest signs and symptoms, move into intervention that is in context with their needs. So in every patient at the point of diagnosis, our interventions should look like this. We should be thinking about self-manual lymphatic drainage to teach every patient, deep breathing techniques, and daily stimulation to the neck and to the unaffected lymph node beds. A daily course of self-manual lymphatic drainage has been incorporated into a number of prospective trials and has shown improvements in lymphatic fluid movement and uptake, and may be a contributor to reducing the risk of developing lymphedema. Exercise. The American College of Sports Medicine recommends exercise for individuals going through cancer treatment. The recommendation is 150 minutes of exercise, either by a combination of aerobic activity and or resistive exercises, 3 to 5 times per week. We should strive to achieve this recommendation in every patient going through cancer treatment. We also want to do extensive education, teaching our patients. They need to be empowered, right? Knowledge is power, and they need to be empowered to self-monitor because they are going to live with this limb for the rest of their lives. And they may live at risk for the rest of their lives. They may never develop swelling, hopefully. But we do want to make sure that they understand how to monitor for the symptoms, the earliest onset, those sensory changes or visual swelling, or indicators that things may be swelling, like clothes that fit more snug or tightly on the affected extremity. Those are the signs and symptoms of your body telling you a story about fluid congestion. We also want to make sure that folks are very aware of meticulous care for their limb, not to instill fear, but to be realistic. A bug bite or a cuticle tear that may not have been a significant issue in the past is now something that could perpetuate a soft tissue infection and very rapidly cause swelling where none had existed before. So the prospective surveillance model allows us to give all of this to our patients at baseline and then repeat these intervention follow-up along the trajectory of care. We have to remember, as we say these things, we think, yes, they're simple, and yes, we're very knowledgeable because we as therapists, we say these words thousands of times a day. thousands of times to thousands of patients. We talk about monitoring for signs and symptoms of swelling. We talk about infection awareness. And we feel like it's very much within our vernacular, but our patients have never heard these terms before. So we have to step back and remember that although we've seen thousands of patients and have said these things thousands of times, our patients have not. God willing, they're going to hear them once. They're going to go through this once. But what I want to be able to instill upon them an understanding so that these words and that these concepts become ingrained into their knowledge base so that they can be proactive in acting if changes occur. If they do become symptomatic over the course of time with measurable changes, clinically meaningful measurable changes, I want to intervene with that compression class 1 sleeve and handpiece, recommending daily wear without activity restrictions, and I'll follow them back in about a month to reassess where their limb is. I'm also going to teach them important self-care strategies, symptom monitoring, the self-manual lymphatic drainage techniques that we talked about. However, for someone who's symptomatic with measurable limb changes, I'm going to recommend that self-manual lymphatic drainage is done more than once a day. In fact, I'm going to recommend it several times, 3 to 4 times per day. I may also encourage self-scar massage because, as I said, if the scar is tight or adherent in the axilla, it may be preventing adequate lymphatic flow in and out of the limb. So why is all of this necessary to be talking about and thinking about integration of prospective surveillance? Well, first of all, what we've seen in the literature is that prospective surveillance contributes to a remarkable improvement in early identification of lymphedema. Early identification means conservative treatment. It means that individuals may not progress on to develop a full-blown stage 2 or beyond lymphedema. That means they may not require compression bandaging and more intensive and extensive complete decongestive therapy. So some individuals will progress, they will go on, and they will need more intensive therapy. But with CDT as a standard of care, we know that we can adequately manage those conditions. Using prospective surveillance, though, we truly hope that it diminishes the risk and decreases the incidence of those more progressed cases over time. So this concept of incorporating prospective surveillance is not just a good idea. This is actually being encouraged and moved forward on a national front by subject matter expert groups and by policy groups. So you, by virtue of being on this webinar, are a bit on the cutting edge in the forefront of being able to integrate this into your clinical practice. In fact, in 2016, a subject matter expert group from the National Institutes of Health convened and over the course of 9 months reviewed the literature in cancer rehabilitation and basically said this model of care needs to be incorporated from the point of diagnosis so that we can identify early any emerging functional impairments and we can treat them more conservatively. We need to incorporate evidence-based clinical assessment tools, those of which we've talked about for early identification of impairment, specifically lymphedema. And we need to assure that by integrating rehabilitation practice into cancer care from the point of diagnosis, rehab providers now become important in informing the plan of care so that individuals who have a diagnosis of cancer and proceed through the continuum have a rehab specialist on their cancer care team. So when these impairments do emerge, because in most individuals they will occur, it's not a matter of if, it's usually a matter of when along the continuum, which is why prospective surveillance is so important. It's not just reactively wait for someone to develop a problem and fix it. It's a proactive approach to identify problems early. That report from the National Institutes of Health subject matter experts was a critical and seminal point because it helped to drive what I'm showing you here, which is the National Cancer Policy Forum report that was published in May of 2018. The National Cancer Policy Forum is a significant body within the National Academy of Health, Science, and Medicine. Previously, this was called the Institute of Medicine. The National Cancer Policy Forum reports will typically drive significant changes in healthcare delivery and in payment structure and in delivery systems. In May of 2018, what we saw was a very important report on long-term survivorship care after cancer treatment, and this report called out two very specific recommendations around rehabilitation, that we need to use rehabilitation more proactively to minimize toxicity and morbidity, maximize independence, etc. And that in many individuals, preoperative assessment and prospective surveillance were the models of care that could optimally help us to fully integrate these services to maximize long-term outcomes for the patient population with cancer. So within that population, obviously, we're speaking about breast cancer, and within that, we're speaking about lymphedema. But we shouldn't lose sight of the opportunity that's before us in engaging prospective surveillance to proactively manage function in this patient population. So the prospective surveillance model takes us to a little bit of a new place in rehabilitation, because typically rehabilitation is reactive. We respond to an event that has already occurred. There's an injury or an accident or a surgical procedure, and rehabilitation is typically consulted to fix the problem. With the condition of lymphedema, traditionally we've waited until we see 10%, 250 milliliters of volume change in a limb before we intervene, and then we intervene with intensive decongestive therapy. What the prospective surveillance model does is it shows us that rehabilitation services can be very effectively utilized proactively. So if we actively seek to identify risk, which we can ascertain at baseline and in the early stages of the conceptualization of the treatment plan, we can prospectively identify the preliminary and very early onset of impairments that are beginning to emerge and tell us that adverse conditions are occurring. So we can utilize the prospective surveillance model in a proactive way, because we know that a majority of individuals getting cancer treatment will suffer some type of functional decline. We know that symptomatic changes that are consistent with the development of lymphedema will occur in a number of individuals, up to 30%. Going through breast cancer treatment. So we should strive to identify those at high risk and follow them proactively so that we can measure for and identify those changes early. When we do that, we potentially prevent the progression to more progressed lymphedema. So I have taken the liberty of the next few slides to provide you, so that you have in written form, many of the studies that I've referred to throughout the course of this talk. I would encourage you to please reach out if you have questions. On the first slide, you had very important information, which was my email address, which I'm happy to share with you. And I'm happy to hear from you if you have questions. Please feel free to let me know if there is a way that I can be a resource to you. And I wish you really the best of luck in incorporating this model of care. It is the way that we are moving in the field of cancer rehabilitation. And breast cancer obviously is one of our largest contingencies of cancer patients. And these women are going to go on and survive. The majority of them are going to live the rest of their lifetime. We want to make sure that we give them a really good quality of life, and we want to make sure that we can prevent those chronic conditions from occurring by catching lymphedema and managing it early. So thank you for your time and for participating in the webinar, and best of luck to you in integrating prospective surveillance.